Welcome everyone and thank you for joining us for today's webinar. Just a little housekeeping before we get started. If you have any questions during the presentation, please type them into the question box in your GoToWebinar control panel. We'll have time at the end of the presentation to answer them. Also, a recorded version of the webinar will be available at a later date. Now, without further ado, we will turn the time over to our moderator for today's session, Dr. Robert P. Wong.
Thank you, Lene. This is Bob Wong. I'm the past chair of the Growing Spine Committee. On behalf of my co-chair, Jim Sanders, our esteemed faculty, and the Growing Spine Committee, I would bid everyone welcome to the SRS webinar, our first webinar on casting for early onset scoliosis. Why, when, and how. Upon completion of the webinar, you should be able to, one, identify both the indications and contraindications of cast treatment of early onset scoliosis, to describe the most important technical aspects of applying proper scoliosis cast, three, discuss common pitfalls in scoliosis casting and how to avoid them, and four, finally, determine when scoliosis casting should be abandoned and other methods used instead. And with that, I'm going to turn the microphone over to Dr. Jim Sanders, my co-chair, who will go over the natural history of early onset scoliosis. Jim?
Thank you, Rob. So obviously my name is Jim Sanders, and we're going to talk about the natural history of early onset scoliosis. I'm going to compare it a little bit to what we know about casting. So we're going to first of all just review some of the basics of early onset scoliosis. Let's see if I can get the slide to go here. Lene, I may need your help moving the slide. So early onset scoliosis, it has a new definition according to the SRS. And it used to be that early onset scoliosis included children who were 5 and under or 8 and under, depending on who you ask. The SRS has now made it 10 years and under. This is really a heterogeneous population. And the concern for all of these children is for early demise from cardiopulmonary compromise. These, if you look here, you can see Fearson's graphs for the expected versus the observed number of deaths in children who had infantile and juvenile scoliosis. And you can see, particularly as you start getting into the 40s, the marked difference in the mortality rate. And for the infantile curves, it starts even at an earlier age. Next slide, please. So the basic problem with scoliosis in the very young is that it can be fatal. The problem is really with the lungs and the deformation that occurs within the thoracic cavity. Bob Campbell described thoracic insufficiency syndrome, which results when someone has a fusion of these areas. So it really puts you into a rough spot. So our goals with treating early onset scoliosis are try to prevent this ultimate cardiopulmonary demise and to prevent doing an early fusion, which can result in the thoracic insufficiency syndrome. Next slide, please. So this occurs in several different varieties. It can occur as an infantile idiopathic and an infantile or as a idiopathic juvenile curve. It can occur as a syndromic type, which occurs in disorders such as Marfan's or Ehlers-Danlos. There are congenital deformities, which constitute early onset scoliosis. All of us are very aware of the various neuromuscular disorders. And there are also the soft bone diseases, which can be metabolic or congenital in things like osteogenesis imperfecta. All of these are early onset scoliosis, and we really only understand the natural history of a few of these. Next slide. So when you talk about infantile idiopathic scoliosis, which is really the classic definition, Min-Meta came up with some criteria back in the 1970s for identifying whether a curve was progressive or resolving. And it really has a wonderful 80-20 rule, and that a thoracic curve, if it has an RVAD less than 20 degrees, most of these are going to resolve. whereas if it has an RVAD of greater than 20 degrees, most of them are going to progress. Meta had recommended also that if you were uncertain, that you should repeat the X-ray in about 3 months and see whether or not the RVAD was increasing. And even if the curve increased, if the RVA decreased, she said this would be a resolving curve. She also described that all phase 2 curves, where the rib on the convexity overlaps the vertebral body, would all progress over time. Next slide. So this is a child with an infantile resolving curve, has a low RVAD, fairly small curve, rib phase 1, and you can see the natural history of this as this child's curve is improved over time. Next slide. On the other hand, this is a child with a non-resolving curve or a progressive curve. This child has a much larger RVAD. The convex rib is overlapping the vertebral body, and you can see what is happening with this curve as it begins to progress over time. Next slide. Double curves are a little bit different, and they may initially look just thoracic, and these curves will typically have a low RVAD. Meta, however, described that if you look at the slope of the 12th rib on the convexity of that lumbar curve, you'll see that it has quite a bit of slope to that. And according to Meta, all of these double curves are going to progress. Next slide. So when you look at the RVD, unfortunately, it's not quite so clear. When you look at Meta's original article, it really wasn't clear whether she was obtaining these x-rays in the supine, the sitting, or the standing position. In her later 2005 article, she indicated that these were all supine, but it's not clear certainly from her initial article. Mike Vitale put together a group of us, and we evaluated the RVADs and the phase on a number of ribs, and we found fairly substantial inter and intra-observer variability. So at least that part of it seems good. Next slide. The challenge, however, is this slide here, and that when we looked at the RVAD, there was still a substantial proportion where the RVAD was greater than 10 degrees variation between the readers. And that creates a real dilemma for those of us who are trying to treat these children, because if I measure an RVAD of 16 degrees, it could be 25 degrees, or the range could even be somewhat broader. So it makes it much harder than at least Men's initial criteria to really determine whether a curve is progressive or not. It also makes determining the natural history of curves that we're treating somewhat more difficult. Next slide. And unfortunately, syndromic curves, which often look like idiopathic curves and may not be identified for a long time, if ever, really behave much worse than idiopathic curves. Unfortunately, we don't really know how much worse any of these curves are likely to become, or how much worse they behave than idiopathic scoliosis. So we're a little bit on our own in trying to figure this out, and we don't truly have a natural history for most of these curves. Next slide. So there are only 4 natural history studies out there, Meta's, and then you can see the other 3 that are there. These other 3 studies all verified Meta's criteria and found that these were reasonable criteria for looking at progressive versus non-progressive curves. Next slide. When we compared these studies to the natural history of scoliosis, the top blue up there indicates the natural history from those 4 studies. And if you look at the top column, that's the RVAD greater than 20 degrees in phase 1, there were 79.8% progressing. Whereas within our casting cohort of those numbers, you can see that that number was 0. If you look at the double curves, you can see the number that progressed from those series. Again, 0% from our study, although it was only 4 subjects. And if you look at the phase 2 ribs, from all of those natural history studies, they gave no denominator, but Meta considered that all phase 2 curves progressed, whereas it was only a small proportion of those that were phase 2 within our casting series which actually progressed. Next slide. So there's clearly a lot of problems when you're trying to compare casting to the natural history. With casting, the curves can be improved or stable rather than just resolving or progressive. And only one of the natural history studies identified some of the curves as stable. So it makes it a little bit difficult for us to actually truly compare casting to the natural history of infantile scoliosis. Next slide. when you look at our results from doing the casting, we found that we had about a quarter of them resolve, about half of them improved but did not resolve, several of them remained stable, and then only a small proportion progressed. In our review back in 2012, we only found that 10% had progressed to surgery in the casting group. We really don't know how rapidly kids progress to the surgical range in the progressive curves from the natural history studies. So again, we're struggling a little bit to compare these two groups. Next slide. This slide tries to summarize some of that comparison. If you look in the first column, it has the single curves with an RVAD greater than 20 degrees, rib phase 1, 80% progressing in the historic controls and compared to 0% with the casting. You can see the single curves, rib phase 2, quoted at 100% versus 16.6%, and in the double curves, a large percentage progressing compared to our very small progression here. So despite the problems with these studies, it really seems that the natural history has been significantly modified by doing scoliosis casting, and it's highly unlikely because of the pulmonary problems that we're going to get further natural history studies in the future. So while these things are problematic, this certainly seems to indicate that casting probably has made a significant dent in the natural history of infantile scoliosis. Next slide. So thank you, and I'm going to turn this back over to our moderator.
Thank you so much, Jim. Just a reminder to all of our participants that are joining us on the webinar, please feel free to type in your questions anytime during the webinar, anytime during the presentations. I will accumulate them. We will have a question and answer session at the end of all of the presentations. Our next speaker will be Dr. Charlie Johnston, who will be talking to us on the role of casting in early onset scoliosis.
So thank you, Bob, and welcome everyone. I'm going to talk about the role of scoliosis casting, which means indications, contraindications, and hopefully some pearls. So who should be casted? Well, Jim has already made the case for treating infantile idiopathic, but we have a large number of early onset patients who are not idiopathic. And I think the first question that when you are contemplating treatment is the child okay for repeat anesthesias? Because really this has to be done under anesthesia. The goal is to either cure it or to control it and delay it, hopefully indefinitely, for progression. And you have to have a family that's going to be all in, because if they're not all in, it isn't going to work. Why do we want to delay? Well, this is pretty well accepted now that early fusion is a form of iatrogenic thoracic insufficiency because it impairs the growth of the thorax and the spine and the intrathoracic contents. Growth-sparing techniques are intended to avoid this, but unfortunately, because of complications in younger patients, which are more frequent, and the fact that you only have a certain number of lengthenings, if you will, before you may start to see premature ankylosis, growth-sparing techniques can actually end up in the same sort of problem, in that you have early fusion unintentionally. So we have many reasons to delay surgery. Again, the earlier we start, the more lengthenings you're going to have to do, and the more complications that may be encountered. The law of diminishing returns may appear quicker, and you have this increased risk of premature fusion. Keep in mind, however, that any delaying tactic must not be detrimental to deformity control or spine and thoracic growth, or else it's not a valuable technique. How young can you start, or should you start? Well, the delay advantage is that you have bigger spinal elements for your surgery. You will be doing perhaps less surgeries, and therefore hopefully having a low or later occurrence of spontaneous fusion. The potential disadvantage of delaying is that by starting later, you may miss a window of what is considered to be the best time to stimulate alveolar growth. Unfortunately, this has never really been proven in the human situation. There is a more real disadvantage in that it may require more complex procedures secondary to more deformity if your delaying tactic does not control. Casting technique, as I mentioned, has to be under general anesthesia, primarily to control the airway in these young children. And Jacques Dastou is going to follow me with all of the technical parts of this, but the take home is remember that the correction is rotational and not lateral pressure, because this can deform the ribs, and we want to mold the cast both for rotation as well as controlling the pectoral area. And Jacques will show you what the final product should look like following the proper steps. Some pearls are to avoid decubiti. This is a potential problem in young children because there's no telling what kind of toys or rocks or other things can get down inside a cast. And so we strongly recommend the use of this type of silver impregnated t-shirt, which can remove these things that can fall down inside of casts. Other complications include the casting, the problems with the casting itself, respiratory intolerance, which may mean that you have to get the cast off quickly, abdominal pressure or so-called cast syndrome. This is a definite problem in a young child who has had a significant amount of traction. And then I'll just show you this example of a cast that was put on with a little too much traction on the neck. And I think everyone can appreciate the 7th nerve palsy on this patient's left side due to the excessive traction. And then when to stop. This is an important part of our treatment. You can see in these 3 x-rays that we start off with a very large surgical magnitude curve, which is nicely corrected with cast number 1. But by cast number 4, we're starting to push the ribs down and the parasol of the ribs is starting to droop or close. And at this point, we are getting a chest wall deformity, and so it's time to stop. I would urge you to read this White and Punjabi paper from, it's an old biomechanical study that has to do primarily with surgical correction moments. This is why we use both axial load as well as transverse load, because remember that a larger curve greater than 53 degrees is going to be more efficiently corrected by traction, and a smaller curve under 53 degrees will be more efficiently corrected by transverse loading. And so obviously by combining these two, we should be able to accomplish our most efficient biomechanical correction. So what do we know about the evidence on the role of casting? Well, as Jim has already spoken about, and I'm sure everyone listening is familiar with the META studies, showing that casting in younger children under 18 months with 32 degrees of deformity or an RVAD of 28 can actually be cured. Patients that are older with larger curves may not have their deformity reduced, but it can be certainly controlled over a long period of time. Our own study from Scottish Rite, presented a couple of years ago, basically showed the same thing, that 12 of the 31 idiopathic patients in this study were cured, and the ones that cured were the younger patients averaging 15 months of age, and with smaller curves at 41. So the non-cured curves, however, are not so bad because they are all maintained either in braces or observation, and none of them have progressed to surgery. So this is hardly a failure in the sense that we're talking about larger curves that are maintained without surgery. And an example here of an 11-month-old with an idiopathic curve. The decision to treat or to delay is made based on the RVAD. This patient had an apical lordosis on the sagittal plane, so actually did not get an MRI right away. The RVAD measures 31, and these are phase 2 ribs, so there's no question really in anyone's mind that this probably should be treated. So the patient gets a metacast and is followed along, and you can see that over time the left thoracic curve is corrected to some degree and maintained in a brace. And then look what happens over time with continued bracing. It's almost as if there has been growth modulation of this curve so that the thoracic curve actually disappears. And at the age of 5, the bracing was discontinued with just this very small residual lumbar curve continuing to be observed. An ideal patient candidate for casting. So what about all the other non-idiopathic patients? Well, there's this very important study from Ankara, and this is a delaying tactic in congenital scoliosis. And as you can see, surgery was successfully delayed for 2 years in this study by casting, even though there was no real correction of the scoliosis during this time. The patients are delayed from surgery, a valuable finding. Our own paper just given at the ICOS meeting in Utrecht on the effectiveness of casting in non-idiopathic patients. You can see our group of patients is 31 patients of a variety of non-idiopathic diagnoses, some stiff, some lax, some congenital. The overall outcome for the entire group shows that there was some correction, minimal correction in cast, followed by a more recent improvement in the curves, which are also including patients who've had surgery. And their thoracic height gain is, again, after surgery, is averaging 4.5 centimeters. If we look at this particular case study, it's an Ehlers-Danlos patient. Interestingly, the spinal deformity is probably a little stiffer than we expected in the sense that the first cast does not show a terrific correction, but over time, the laxity is eventually exploited, and as you can see at 2 and at 4 years post-op, the post-casting, the patient is doing well and simply being observed, so that this is a very viable treatment for some syndromic curves. We considered that our group of non-idiopathic patients were successfully treated if they remained non-operative. And you can see that the patients who were non-operatively managed, in other words, they've never gone to surgery, got about 30% correction in the cast, and they got about 4 centimeters of height gain during this time of casting. 8 are now braced and 3 are simply being observed. So the patients that went on to surgery that we might consider then were not so successfully treated in this group did not get any correction of their curve during the casting, and their operative procedures, as you can see, mostly growing rods, a few one-and-done fusions, and what they have obtained again is an improvement in their height by 5 centimeters and an improvement in their Cobb angle, as you would hope to get. But they have simply been delayed by this treatment. So in looking at success versus partial success, the patients with non-idiopathic scoliosis who are going to benefit from casting are going to be the younger patients who get a little bit of correction in their cast, though as you can see here, when we compared the two groups, there really was no statistical difference to be able to predict the outcome. And so our feeling is that it's worth a try in almost any diagnosis if you know how to do this. So casting in non-idiopathic scoliosis may achieve a significant improvement and delay if the patients get about 30% correction. That's the take-home number. And the older patients who don't get any correction in cast, then this is only useful as a delaying tactic because they will come to surgery. So the last evidence on the role of casting in surgical magnitude is this paper that we published a couple of years ago comparing growing rods with casting. Peter Sturm is going to talk about this study in more detail. The take home that I wanted to emphasize, however, is that the delaying tactic, casting, is not detrimental to the eventual spine growth in this group of patients. So thank you for your attention, and I'm going to turn it over now to the next speaker, Jacques Destoux.
Thank you, Charlie.
Let me just take the prerogative again to let all the participants and actually invite the participants to participate and ask questions throughout the entire presentation and webinar. And our next speaker, Jacques Destoux, will be talking to us about the actual casting technique. Jacques.
Thank you, Charlie, and thank you, Bob. I'm trying to advance this slide. Oh, here we go. So this technique was first described by Drs. Cottrell and Stagnara in the late 1950s and published in 1964. And then it was popularized for treating infantile scoliosis by Miss Min Mehta, as you've heard. This is a table that was used by Miss Mehta to apply the EDF cast. And this is a table that we designed in Salt Lake City, and it's basically adapted from Miss Mehta's table by one of our orthotists and one of our PAs. It allows for induction of anesthesia with the patient on the table, and the cast can be applied without having to move the patient. The horizontal bar at the head of the table drops to facilitate anesthesia access, and the tabletop drops for application of the cast. This shows the foot slings to keep the hips flexed at roughly 30 degrees, the sacral bar to support the sacrum, and the transverse bar on which the head rests. The materials that we use are a head halter, a 6-way stretch t-shirt, felt pads about 3/16 inch in thickness, cotton cast padding both 4-inch and 2-inch, regular stockinette, plaster sheets with 4 layers on the front and on the back, 4-inch plaster rolls, fiberglass casting material, and a 4-inch elastic wrap, as well as scissors, duckbill, and a commercial stapler with 1/4-inch staples. I preferentially like to go over the shoulders, but if the apex of the curve is at T8 or below, I think that the shoulder straps can be optional. While still in the pre-anesthetic room, the patient is fitted with a 6-way stretch t-shirt or a turtleneck over which 2 layers of 6-inch stockinette are applied. The stockinette should be cut long enough to shield the face while the cast is being applied. Following this, a 2-inch stockinette is applied to both arms, and this will be used to help stabilize the arms on the casting table and also protect the arms from the wet plaster and fiberglass. Under general endotracheal anesthesia, the eyes are protected with tegaderm, and earplugs are inserted into the external ear canal and covered over with tegaderm to protect from the high decibel volume of the cast saw in the vacuum. The endotracheal tube is then securely fastened, the stomach is suctioned, and a bite block is placed to prevent the teeth from pinching off the ET tube when traction is applied to the head. You can also add a foam pad under this rope to protect the ears and the face from the traction rope. We then apply a 2-inch stockinette approximately 5 feet in length between the 2 layers of body stockinette and cinch it over the iliac crest. We tie a simple knot at the level of the greater trochanter and a second overhand knot approximately 6 inches below the simple knot. This allows us to get excellent control of the pelvis. We then tie these pelvic bands to the traction straps on the foot end of the casting table. After that, we move the patient down the table by approximately a foot so that the head rests on a gel cushion on the transverse bar and the sacrum rests on the sacral post. The arms are then stabilized to the casting table, as illustrated, with typically the right arm being slightly more abducted than the left for a left-sided curve. We then place the feet in the sling in order to flex the hips for approximately 30 degrees. With pelvic traction in place, we apply cervical traction, and the amount of weight is usually roughly 40% of the body weight. The tabletop is then lowered, and looking at the mirror at the head of the table, one can appreciate the rib prominence on the convexity of the scoliosis. Prior to application of the plaster cast, we perform a practice maneuver so that all participants will know exactly what to do after application of the plaster. Comma-shaped felt pads are then placed on the anterior superior iliac spines to protect the iliac crest and the ASIS. Following this, a contoured felt pad is placed directly over the rib hump, which can be readily seen in the mirror, and another felt pad is placed high up in the right axilla. The felt pads are then held in place with a thin layer of cast padding while an assistant stabilizes the trunk. We then apply a 2-layer thick folded strip of cast padding over the sternum anteriorly and over the interscapular region posteriorly. These are held in place with 2-inch cast padding straps, which start at the lower costal margin anteriorly, then go over the shoulder to end up on the opposite anterior superior iliac spine. The arms are then covered over with a thin layer of synthetic cast padding. This is the appearance of the patient seen from the bottom end of the casting table just prior to application of the plaster camisoles. The mirror helps you see the rib hump and allows you to position the felt pad on the rib hump and apply the corrective forces at the appropriate location. The anterior sheet of 4 layers of plaster is dipped into tepid water and placed on the anterior torso, taking care to apply tension to the shoulder straps and on either side so as to avoid any wrinkles. Similarly, the posterior sheet of plaster is dipped and applied to the posterior torso in a similar fashion. Care must be taken not to infold the shoulder straps on the posterior aspect of the cast. We then use a 4-inch roll of plaster to securely fix the sheets of plaster to the patient. Note that we apply tension on the roll of plaster just proximal to the iliac crest in order to get a very snug fit and to capture the pelvis, which serves as a foundation for the EDF cast. In this patient, we are treating a left-sided thoracic curve, so we apply anteriorly directed derotational forces on the left 8th, 9th, and 10th rib, taking care not to laterally compress the ribs with the palm of the right hand, noted by the arrow. The left hand is pushing down posteriorly on the right 5th and 6th ribs, and also attempting to elevate the right shoulder in order to get a little bit of lateral flexion to maximize the correction of the left-sided curve. This illustration shows that derotational forces are applied to the left side of the rib hump. With the fingers of your right hand, you try to pull up on the rib hump and to flatten out the rib hump on the left. At the same time, you are pushing down in a posterior direction on the right 4th, 5th, and 6th ribs, while one assistant stabilizes the pelvis, and the other assistant uses a hand to prevent the left shoulder from coming forward, and the second hand posteriorly to smooth out the posterior portion of the cast. Traction provides elongation of the torso. The spine is derotated by trying to flatten out the rib hump and by applying anteriorly and medially directed forces on the rib hump, avoiding any lateral pressure on the lateral side of the chest wall. See arrow B. A posterior and medially directed force is applied to the ribs at the proximal concave side of the curve with an attempt to elevate the shoulder on the concave side, which constitutes the flexion in an EDF cast. Once the cast is firmly set, we then overwrap it with a thin layer of fiberglass casting tape. We apply shoulder straps that were fashioned from the 4-inch roll of casting tape, usually 3 layers in thickness, followed by another roll of casting tape. The finishing roll of fiberglass is then applied. We then overwrap the cast with a wet elastic wrap that will help bond the fiberglass to the plaster. The tabletop is then raised up to support the patient. We remove the headrest bar and sacral post bars distally to decrease the pressure on the occiput and on the sacrum. The elastic wrap is then removed, the feet are lowered, and the pelvic straps are cut just above the simple knot and removed by pulling on them distally in order to decrease the pressure on the lower abdomen. Next, we draw our trim lines, beginning with the neckline at the superior level of the sternal notch. The next line is approximately 1 to 2 centimeters above the pubis in order to allow the hips to flex just past 90 degrees. We then draw a mushroom-shaped thoracic and abdominal window with 2 anterior flanges to prevent outflaring of the lower costal margin. Once the trim lines and windows are drawn, we cut them out using a cast saw, starting with the thoraco-abdominal window. It is important to do this quickly and efficiently, as the CO2 levels can rise quickly, particularly in the very young patients. It is important to make sure that the arm trim lines permit enough adduction of the shoulders to allow the child to get their hands to their mouth. Distally, the cast should be trimmed to allow the hips to flex just past 90 degrees. We then cut the stockinette, which is then stapled to the cast using a commercially available stapler. The edges of the felt pad in the right axilla are also stapled down to the cast, and the stockinette is pulled up over the pubic portion of the cast and stapled, and the same for the upper sternal portion of the cast. The patient is then turned prone on 2 transverse bolsters, making sure that the bolsters are aligned with the sternal and pubic portions of the cast to avoid any intra-abdominal pressure. A posterior window is then cut out opposite the rib hump, in this case on the right side for a left thoracic curve, in order to allow for further derotation and chest expansion. Once again, the stockinette is cut and stapled down to the cast. The same is done at the proximal and distal portions of the cast. The patient is then turned into the supine position, and a finishing roll of 2-inch fiberglass tape is applied around the waistband. The anterior flanges are then flared out slightly with a duckbill in order to allow for more chest expansion. The child is then returned to the post-anesthetic recovery room and allowed to resume activities as tolerated. In most cases, we usually obtain a standing AP or PA X-ray of the spine to assess the degree of correction provided by the cast. These are the X-rays of a typical patient, with the X-ray on your right taken after application of the 3rd EDF cast 7 months later. And again, typically we do our X-rays standing and after they are out of surgery. The center photo shows a typical cast with examples of customization on either side. Sometimes the customization can be very creative, particularly around Halloween. This is Ms. Mehta and a group of casting patients when we hosted a casting workshop in Salt Lake City back in 2005. And that concludes my portion of today's session. Now we'll turn it over back to Dr. Wang.
Thank you so much, Jack. That's a wonderful, wonderful picture. Peter Stern will give us the final presentation of the evening and go over the results of casting in early onset scoliosis.
Thanks a lot, Bob. So as you've already heard from people, this is not the same as adolescent idiopathic scoliosis. This is not just an orthopedic problem, but it is a significant medical problem. Big curves in little people that are untreated are really an enormous problem. And as Jim Sanders referred to before, Pearson's study from Sweden, adolescent idiopathic scoliosis, observed deaths and expected deaths are the same. Juvenile observed are much more, and infantile even more so. So this is something that really needs to be treated, and needs to be treated early. And it's fairly obvious when you look at what happens with curves, that severe curves affect the space available for lung and alveolar growth over time. So what are the goals of casting? So first is to control the curve. Second, and most importantly, is to promote growth. And then also to maintain adequate pulmonary function while we're doing the casting and getting the spine and chest to grow. So again, as Jacques has referenced, EDF casting initially introduced by Cottrell for adolescent idiopathic scoliosis, and then adapted by Mehta for infantile scoliosis or early onset scoliosis. You've heard about this study already, Mehta's study in JBJS in 2005, 136 patients, 100 idiopathic, 36 syndromal, full correction in 94, average age at follow-up is 3.5 years, partial correction in 42 patients. I think you'll hear this a lot. The take-home message from most of these studies is the best results are in kids who are truly idiopathic or casted early and who have smaller cobs when the casting is started. This is a multi-center study that Jim Sanders was the lead author on, published in 2009, the first study published in the US. 55 patients with progressive EOS, curve decrease in 49 of the 55 or 89%, surgery in 6 or 11% of the patients. And again, you need to contrast this to the natural history, which, as Jim pointed out, is a little bit less clear than we think. But we know certainly that these results are much better than the natural history is going to be. Again, best results, kids under 20 months of age, Cobb less than 60 degrees, idiopathic curves, and these kids are going to be in cast for a while, casting for more than a year for complete resolutions, even the ones that do resolve completely. So this is a patient of mine presented with a curve of about 55 degrees. There's an x-ray and a cast, and the curve did not spin around. That x-ray is backwards. That's after a year and a half of casting. Curve now measures 11 degrees. When the curve gets to this point, the kids come out of the cast. They go into a brace full-time for 6 months, then sleep in a brace for 6 months. And if the curve is maintained this small, they come out of the brace completely. If the curve is bigger and we haven't really achieved complete correction, we continue bracing as the kids get older. That kid was 16 months old at the time of initiation of treatment. Study out of Shriners in Chicago, 74 patients when they reported it. 28 were still in treatment, 30 had been converted for TLSOs, and of those 74 patients, only 9 had gone on to surgery. This was a mixed population of both idiopathic and syndromal curves. Again, same take-home message, best results in idiopathic kids and when the casting was started under age 2. So this is the study out of TSRH that Dr. Johnston referred to previously that they published in 2013. Matched cohort of 27 kids in cast versus 27 kids with growing rods. Over the course of treatment, there was a similar increase in spine length, which is extremely important because if we're doing the casting and not maintaining growth of the spine on the chest, we're really not doing anything. But this study, similar increase in spine length, complications in 1 of the 27 cast kids versus 15 of the 27 growing rod kids. And the kids who went on to surgery at an average of 1.7 years post-casting. So even if you can't improve the curve, if you can hold it and you can avoid earlier surgery, we're certainly doing something positive in these kids. So again, another patient of mine, this was a 3 or 10-month-old girl who had been casted elsewhere and came to us with a 74-degree curve. She was casted until age 6 years and 11 months. It takes a brave and cooperative family to do this. But at the time of surgery, her curve was 61 degrees, so it controlled her curve. And at this point, she underwent magic rods and has done very well since then. So again, there was no expectation whatsoever that we were going to cure the curve with casting in this kid, but we did put off surgery for almost 3 years. And again, you heard from Dr. Johnston the argument in favor of that. I think there are some people who would argue that there is some evidence that multiple anesthetic in young developing brains may not be the best thing, so we need to weigh that a little bit against continued casting in some of these kids. And if we have growth modulation that doesn't require multiple trips to the operating room, I think the paradigm may change a little bit. But I think we all agree that later surgery is a better thing than earlier surgery. So what are predictive factors and whether or not casting is going to work? We know that one of the predictive factors is age, and another predictive factor is Cobb angle. But is there anything else, RVAD or rotation or rib phase? And no one has ever been able to show that any of these things are predictive for cast success. So there are kids who do very well, who sometimes you wouldn't expect would do very well, and other kids who you would think fit into the category where the cast should be curative, and those kids don't do as well and end up needing something more done. And none of these things seem to be as predictive as we'd like them to be. The only thing that really seems to be predictive is the X-ray in the first cast, and this was reported from Boston Children's last year. Correction more than 50% in the cast seems to be consistent with cast success. So again, this is a patient with approximately a 40+ degree curve. This is an X-ray in traction, and I don't really think it's the cast as much as the curve flexibility. So this is an X-ray in traction before the cast is put on, and then this is the X-ray in the cast, and the cast is down to about 19 degrees in both the traction film and the cast film. Jacques alluded to X-rays in the cast. I think we've all tried to cut down on X-ray exposure for these kids. So in my practice, they get an X-ray in the first cast, supine in the operating room, and then they get an X-ray every 6 months out of the cast. And I know there are people who've gone to doing it once a year out of the cast. I don't think that really affects your treatment because, most of these kids are going to be in the cast at least for 6 months, if not a year, before you make any kind of treatment decisions. So take homes from all of these studies. Best is to start early, under 18 months. I've started in kids as young as 6 or 7 months. I'm not sure there's any age that's really too young, as long as the kids are big enough to fit on the table. Idiopathic curves, the chances of cure are better. And smaller curves under 60 degrees as well, the chances of cure from the cast alone are better. Technique definitely matters. Flexibility matters. And certainly you need families that buy into this and that are cooperative, because you're going to be at it for a while and they're going to be at it for a while as well. So again, 20 months old, idiopathic when we started. This was at the end of treatment when we came out of the cast and switched to brace treatment 18 months later. So you're going to be at it for a while, but the results are good in the right group of patients, and even in the kids that we don't get better with casting, we still can temporize and do surgery later in these children as well. Thanks.
Great, thank you, Peter. Now we've come to our question and answer session of the portion of the webinar, and there's thank you to all the participants who have submitted questions. I'm going to apologize. There's been significant interest, and I apologize if I don't get to all of the questions due to time. But the most frequently asked question, and I'll pose this question to the entire panel, in order from Jim to Charlie to Jacques to Peter. The most common question for the entire panelists is the faculty's protocol for casting, specifically with regards to the frequency of cast changes and the number of casts duration. Jim, do you want to take that on first, please?
Sure. We kind of came up with this protocol based upon how fast the children were growing, and they seem to grow out of their casts at different rates. Younger children are growing faster than older children. So what we found is that most 2-year and under children, you really need to change the cast about every 2 months, or they simply grow out of it. And in general, 3-year-olds, it's about every 3 months, and for 4 and up, it's about every 4 months. Clearly, you need to take some flexibility based upon how fast the individual child is going. But that protocol seems to work pretty well.
Thanks, Jim. Charlie?
I don't really have anything to add. I think Jim covered it perfectly, that we follow pretty much the same protocol.
Great. Jacques and Peter, do you have anything else to add, or do you follow the same protocol?
I follow the same protocol with respect to the frequency of casting, and I sort of keep going as Charlie said, when you start getting sloping ribs, then you have to talk the family into an alternative type of treatment, although sometimes in the population that I get, they would like to be casted for a long time and would like to avoid surgery. But I think there is a time that you need to abandon the casting and proceed with growth-friendly surgery.
Yeah, we follow the same protocol as well.
Great. Second question that was most frequently asked is there an upper age limit and upper cob limit as to when you would not consider casting? Jim?
I guess we're going in the same order. So upper age limit, I don't know. I've been using this primarily for infantile curves. I've tried a couple of slightly older children just to get the curves down smaller. I have certainly not gone in the direction of the 8, 9, 10-year-old child. I think that they are generally too big, and we're probably not going to get the correction we would like. Hopefully we'll find some other solutions for those children. In terms of the upper size of the cob angle, I don't think it's really the absolute cob angle that matters. What you want to know is that you can actually make that curve smaller by doing your casting technique. And if I find that I'm getting a large curve that is stiff, that I'm concerned is beginning to create cardiopulmonary compromise, then I would suggest that we not do casting for that child.
Charlie, Jack, Peter?
So I would probably call the upper limit for casting is a child who has enough stiffness and enough size that you are going to have to apply really an excessive amount of molding force, which is not going to be tolerated well either by the child or by the family because of complaints of discomfort and difficulty with sleeping and activities of daily living. And at Scottish Rite, of course, we have a very great experience with halo gravity traction. And so if we have a child that we think is really too large or too stiff for casting, and I don't have a number to throw out there, but we have a vast experience with traction, and this is a great way to reduce the size of a curve to something which then you are actually very comfortable in casting after a period of, say, 4 to 6 weeks in traction. So I would just offer that as an alternative when you are faced with a patient who doesn't want surgery but clearly has to have reduction in curve, increase in length, and more importantly, improvement in the chest wall.
Bob, I just wanted to make the point that I think you need to be honest with yourself. And even in the very small kids, if you're losing ground, if you have a big curve to start with and you're losing ground, I think it's time to think about doing something else. And, you know, if that means switching to some growth modulation or growth preserving technology that's surgical, even in the smaller kids, I think you need to come to that decision.
And this is Jacques here. I would agree with everything that was said. I will cast, depending on the parents' wishes, up to the age of 4 or 5, but rarely institute any new casting after the age of 5, hardly ever. And as far as the degree, the comp degree, I've casted as high as 80 degrees, but what I like to do is I like to take a supine AP traction film in my clinic. Our techs can do a good traction film. And sometimes you'd be surprised that you get an 80-degree curve down to about 40 degrees. And I've been pleasantly surprised. And those I will certainly give a try at casting. If they're very rigid, I agree with what was said by Peter as well. So, and
as a pre-casting to determine your prognosis?
I did traction film on most of my patients, and as it turns out, it's can be similar to the X-ray in the first cast, and that's what the group I think has decided to do. But I think in my hands, the traction film, it does two things: is it assesses the flexibility of the curve in the clinic, and it gives me something to shoot for in my casting. And if I can get the first cast X-ray close to my traction film, I'm usually pretty happy with it.
Great. And the final question for the panelists: how do you know when to take a casting holiday? And do you just let them go, or do you put them in a brace?
So I think I'm working again here. I used to never take a casting holiday until I found some children who'd been out of the cast for a while and actually seemed to do fairly well, and some of them became somewhat more flexible with it. What I've typically done for the children who really, really want a holiday is to have a brace made for them while they are out of it. Generally, though, during the summers and the curves which are somewhat stable, I take the pantaloon from the Gore-Tex that we're using for spica casts, turn it upside down, use it as a shirt, and apply a waterproof cast. I don't think you can get the same amount of correction in the cast. You can't apply the same amount of force without creating sores, but it allows the child to go swimming and to participate in some, get bathing and get wet during the summer. And then I typically will go back with a standard cast during the fall and the winter months.
To me, if the child is under 20 months of age and it looks like we may win and go for a cure, I'm a little hesitant to give them a casting holiday. But on the other hand, if they are older and the curves are greater and we're just buying time, what I do is before the summer starts, I will mold them for a cast at the same time as brace, I should say, at the same time as I apply the last cast, and then give them 2-3 months off in the summertime with a brace, and then resume the casting in the fall.
We've gone to summer bracing because a lot of families really want it. It's really, family sanity is important in this, I think. And we do the same thing. We'll measure them for the brace while they're asleep for their cast. And then when they come out of the cast, they go right into the brace. And we'll maintain them in that for the summer and then take them out and put them back in the cast at the end of the summer.
Great, thank you. Thank you to the panelists. I appreciate that. Thank you, everyone who have joined us and participated in the webinar this evening. I would like to thank our world expert on casting and early onset scoliosis, Dr. Jim Sanders, Dr. Charlie Johnson, Dr. Jackie Astuse, and Dr. Peter Stern for educating us on EDF casting and its indications. Hopefully, everyone has had as much education as I have had and learning. Thank you to the Scoliosis Research Society staff, Courtney, Lene, and Lily, for making this all possible. And this will conclude our webinar for this evening.